So do you want me to start?
Yeah, no, I'll just give a brief intro.
Sure.
So we have in the 2021 CTMC webinar series, we're very blessed to have Dr. Lehana Thabane from McMaster University, and he is going to be speaking to us more about some of the most challenging studies to design the early phase pilot and feasibility trials. So with that, I will hand it over to him.
Thanks, Will. I'm going to share my screen. I think you can already see it. We now have established a tradition here of studying every presentations like the one I'm doing with some land acknowledgement, and I'll explain what this is. It is really an act of reconciliation that involves giving a statement such as this to recognize the indigenous inhabitants of the land where we live. To acknowledge is one way to show respect to indigenous peoples for the enduring connection with their traditional territories and its histories. I work at McMaster and also St. Joseph's Hospital, which is really part of our healthcare system. We are privileged to provide care on this lands that indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all indigenous peoples as keepers of this land. We acknowledge that where I am with St. Joseph's Hospital is located on the traditional territories of the Mississauga and Haudenosaunee nations, and within lands protected by the Dish with One Spoon Agreement. The Dish with One Spoon, One Pan Agreement was created to bind nations of the Haudenosaunee Confederacy to the great law of peace. The dish represents the shared land, while One Spoon reinforces the idea of sharing the resources of the land in the spirit of mutual cooperation and peace. So this is really an updated version of what I once gave to this group. I gave a similar talk last week to another group of colleagues working in transfusion medicine. Now, this work that I have done with a group of colleagues in the UK, from the University of Aberdeen, Sheffield, Queen Mary, University of London, and Oxford, Kiel. And of course, I am from McMaster, and we've been working on this collaboration since 2011. So I'll tell you a story about what we did before 2016, and we'll get a sense of why 2016. And then, I gave this talk before the pandemic, trying to give people a sense of what we had been able to do between 2016 and 2019, and then what our current hopes are going forward. So before 2016, there was definitely evidence showing that there was substantial variation in practice with many of the studies that claim to either report pilot or feasibility study, not doing a good job because reporting was inconsistent. And the terms pilot and feasibility studies were used interchangeably in some cases. Some people thought they were the same, and others actually thought they were different. Right? We all know that in research, words really matter. And therefore, one of the things that I'll go through is really whether the two terms are the same or they're different. And if they are, in what way are they different? If they're the same, in what way are they the same? One of the challenges we had was that many journals had no editorial policies on how to handle pilot or feasibility studies. And this was one of the problems we're facing. There was evidence showing that in other cases, editors would arm twist authors to actually add the word pilot if they were actually trying to publish a small studies. And of course, if you're desperate and you want to get published, you'll do exactly as the editor tells you to do, even though the study was never really designed as a pilot or a feasibility study. The empirical evidence was also showing that reporting was suboptimal in so many ways, with a lot of reported studies putting more emphasis on hypothesis testing no clear feasibility objectives or outcomes, without any mention or reporting of progression criteria, which would guide actually how they interpret the results, or they would move on to the main study after doing a pilot. The analysis plans were never adequately described, and clearly one of the things that was troubling was that there was never even any mention in many of these reports that the study had been done to inform the design of future studies. So clearly there was a problem with the way the practice was going. And this was a program in the UK which was designed to actually support pilot and feasibility studies in surgical studies. And it was clear that they were experiencing lots of problems, especially with the effort that are trying to enhance the rigor of studies in this area. But people were still not doing a good job with pilot and feasibility studies. Now, others were worried that pilot studies really are the type of studies we shouldn't really be spending a lot of time on, with diminishing resources to support trials. Pilot studies could be a waste of resources. Why don't you just go straight into the main study other than waste resources on pilot studies? But while these arguments were taking place, the evidence continued to emerge that actually failure to do piloting was actually leading to waste of resources rather than saving resources. This was evidence coming from the UK program that doing pilot studies was actually saving their healthcare system about $20 million a year. So obviously, this was important because empirical evidence was showing that lack of inadequate assessment of feasibility was the number one reason why trials were failing. There was review after review showing that poor accrual in studies was the reason why many trials were prematurely stopped. And this continues to be the case in many areas. So in the past, really, in short, the practice of how these studies were conducted, designed, analyzed, and reported was inadequate if we really judged by the quality of the reports. And certainly the evidence was becoming clear that failure to do a good job in assessing feasibility of studies was one of the primary reasons why we were actually wasting resources with studies that could not accrue to completion. So we started in 2011 trying to see whether we could actually change this, and we then put together the paper describing the methods and the processes of how we're going about to do this. While when we started, we were hoping to actually look at how people could enhance the reporting of the final reports of the studies, we very quickly realized that it was a mammoth undertaking. So we decided to focus on a smaller part of the studies, which were those that use randomized controlled trial design. And therefore, we focus on using the consult statement as a starting point, and then see whether we could find ways to extend it to the reporting of pilot randomized controlled trials. But as soon as we started the process, we also realized that as a group, we couldn't agree on whether pilot and feasibility studies were the same or they were different. So we started then working with stakeholders and trying to get feedback, from everyone who was working in this area, including actually targeting people at various conferences to see whether we could clarify this. And that led to the paper, which we call the definitions paper. And within that paper, it was becoming clear that we could actually put a framework to this, because everybody thought that when you're trying to design the main trial, there's a lot of things you're uncertain about. And all those things that you're uncertain about fall under a bigger umbrella of feasibility. And therefore, you could do an assessment of feasibility of whether you can recruit, feasibility whether you can consent, or randomize individuals, or even implement the intervention itself, and so on. And then a pilot study would actually be a miniature version of the exact replica of the main trial. So feasibility doesn't necessarily mean that a study you design to do to assess that feasibility needs necessarily be the same as the main study in terms of design. So there was a larger concept of feasibility, And then within that, you would have a pilot study to be able to see whether you could replicate the larger study on a smaller version. So feasibility study asks whether something can be done, should we proceed with it, and if so, how, while a pilot asks the same question, except with the specific design feature that it's the same as the main study. So the corollary to this is that all pilot studies are feasibility studies by definition, but not all feasibility studies are pilot studies, as you can imagine. So that's kind of really clarified the concept, and the paper really gathered a lot of attention from the community when it came out, and it continues to gather. This was really the situation way before the pandemic, and I'm sure it's definitely gone up quite a bit since then. We then published the first consult extension to pilot trials in 2016, hence why 2016 was a benchmarking year was go through this discussion. This was published in BMJ at the same time published in the New Journal Pilot on Feasibility Studies, and I'll come to this in a minute. So the checklist really applied to pilot trials which are done in preparation of a future definitive trial. So we had no restriction as to whether you would call it a pilot trial or a feasibility trial, but the goal was that you are actually doing it in preparation to gather information to help you design the main trial. It didn't apply to internal pilot trials, which are really, the initial phases of a study that has two phases, where you might want to gather some information about any aspects you're certain about in the beginning phase. We call that an internal phase or internal pilot phase. And then you roll over the patients in that phase into the main trial. So this checklist was only done for studies that are external pilots. You would run it to completion, and then based on the findings, determine whether it would be feasible to proceed with the main study or not. We provided the consult checklist item and the extension to pilot trials side by side. We identified items that remained unchanged, those that had to be modified, any new items that we thought were specific to pilot trials, and then some that were already on the list, but we thought were not applicable to pilot trials. So this is what you will see when you look at the checklist. It has two lists, which is standard checklist, and then the extension pilot trials. And anything that had a rate thing was the additions or the modifications that we added to those. Like here, we just added the word pilot and feasibility randomized trial in the title. Now, anything that we didn't change, but we thought was still applicable, we just left it blank, like these two items, eligibility criteria for participants. We thought this is equally as important for pilot trials and therefore remain the same. We introduced a new item such as how many participants were identified, consented, because for many pilot studies, this could very well be one of the goals of trying to assess whether you could be able to actually identify participants for a study, for a trial, or even get them consented. Same thing here, we said, if applicable, pre-specified criteria to judge whether and how to proceed to the future trial would be essential for a pilot trial, and therefore this needs to be reported. We encourage people to actually, provide the rationale for the numbers for the pilot trial, while in most cases, for most trials, we would actually provide the calculation and with all underlying assumptions for that calculation for the sample size. Now, methods for additional analysis, such as subgroups and so on, we thought this is really not applicable for pilot trials because they're very small trials, and therefore really doing subgroup analysis will not be appropriate because they're not designed for statistical significance, let alone this type of additional analysis. Similarly, reporting things in absolute or relative terms in terms of effects, we thought this is really not applicable because trying to determine magnitude of effect in a pilot trial is a secondary goal because they're not designed to even assess the significance of those effects. We encourage people to edit this as a new item if relevant, important, unintended consequences. A lot of things that you may not be aware of as you're running the pilot, which could be useful in designing the main study. You really would like to capture those. Ultimately, we also encourage people that they should actually look at and report or discuss the implications of progression criteria to the main study based on the results, because this would be essential in really cementing those lessons learned about feasibility with regards to the future trial. We then ended with encouraging people strongly to actually make sure that they consider their approach to ethics to a pilot trial the same way as they would for the main trial. They should get it approved by the research ethics because ethics of doing this is equally as important. I'll come back to this issue later to show you that even the practice in how we approach consent process for pilot studies or pilot trials is still inadequate. We then provided an explanation, an elaboration as to why each item was important, and provided examples of best practices, which is what you would commonly see with every construct checklist. So this just provides a specific example of how to deal with listing of objectives, primary and secondary, and so on. The third thing that we did was to suggest some changes to the typical construct flow diagram. In particular here, we wanted to actually show the number of participants that were screened at the beginning, and ultimately make sure that it's very clear how many individuals were used for each feasibility objective. So this will be an essential element, because part of what you may be interested in is assessing whether you can actually recruit. So how many you have to screen to be able to get what you want is essential. And ultimately, in the main trial, you would actually report things by arm. But in our case, the primary focus is on feasibility. And you want to be able to see how many individuals were used to address each feasibility objective. And then we provided the consult extension to reporting of the abstracts for pilot and feasibility trials. This is the standard checklist from the consult extension to abstracts, and we extended it to pilot trials and provided some examples of how you could actually use that checklist to make improvements to existing abstracts, or make sure that your own abstract is actually done well. About the same time, we're having discussions with lots of publishers about really how to change the landscape of how people approached and practice pilot and feasibility trials. One of the discussions we had was with Biomed Central, and looking at the landscape, it was clear that this was a major gap in providing a forum for publishing pilot and feasibility studies. So we created a journal which we launched in 2015. And Jill and I have been editors-in-chief for the journal. And many of our colleagues who were really part of our group were editorial board members and remain as such for today. We continue to run several workshops at conferences and different institutions, similar to the one I'm giving today to you. And we created a website that provides all the resources, at least in one area, for people to be able to see. So I encourage you to visit the website and see what else has been done since then. And then we talked to some of our colleagues that have been working with us in the area to write editorials for their favorite journals. And Peter Gregg is one of our colleagues in the UK. He wrote one for the Journal of Clinical Epidemiology. And then we wrote one with one of my former mentees in Brazil for their journal. And then we started really seeing a lot of other editorials being done by other colleagues in different journals. So if you have your favorite journal and you think the way they actually approach the studies is still inadequate, it may not be a bad idea for you to consider writing an editorial and introduce the consult checklist to pilot trials as a starting point. But we see more attention now being paid to paths in many clinical disciplines. Thrombosis and spinal cord research is one of those two areas. Unfortunately, we still have a lot to do, because in so many other areas, the practice remains inadequate. So it was clear looking at this that 13% of published pilot and feasibility studies in anesthesia journals were still inappropriately labeled as pilot and feasibility studies. Perhaps because of some of the editors forcing people to call something a pilot while it's not. We can't really know the exact reasons why this continues to be the case. And then one of my colleagues here, we looked at whether, are people really doing a much better job? Now we see that people are publishing protocols, including protocols for pilot trials. And looking at what we see, we only find about 20% really explicit about looking at reporting criteria of how they will interpret the findings to determine whether they can proceed to the main trial. So clearly, this continues to be a problem. This is one of my trainees who worked with me last summer looking at whether the way we approach consent for pilot and feasibility studies is actually helpful. And the evidence was clear that it is inadequate. The reason being, people are afraid of revealing the feasibility nature of pilot trials when they are sharing the information with potential participants. And quite often the argument that people use is that, people may not want to participate once they hear that this is a feasibility study. It's not the main study, and therefore they are reluctant to tell them the truth. But there is no evidence to suggest that revealing that a study is a pilot or a feasibility trial could lead to challenges with recruitment. So this was just what was happening here at McMaster in one of our research ethics board. And I would say that there's a lot of this happening in many research boards or institutional review boards. So you can see how much work still needs to be done. The Tri-Council policy statement is a major document that guides all research involving human beings in Canada. And it's very clear that when you're running a pilot, you have a responsibility to make sure that you communicate the purpose and the nature of the pilot trial to all participants. And the reason why is this clear is because I have been a member of this group, which really looks at updating this document for many years. And one of the things I encouraged them to do is to be that explicit, encouraging people to do a better job when they design their studies. But the practice is far from getting to that standard at all. All right, so what's next? We have a long list of to-do things, which really are things that remain not well articulated, or at least there's no clarity about how they could be approached regarding pilot and feasibility studies. One of them is sample size. There's lots of rules of thumbs out there, some of which are based on good principles, some of which really we don't have clear sense of how they came about. And we'll continue to work on that to see how we could improve it. What about protocols? Everybody now is publishing protocols for pilot trials, and we encourage people to do the same in order so they could pay attention to how they design them. And we're working on adapting the spirit guideline appropriately for pilot trial protocols as well. Should they or should they not be included in systematic reviews? So we're working on that issue as well. We have 2 PhD students who are currently also looking at issues of progression to main study. How should this be approached? What should be the guiding principles? Right. And then we're looking at what about those pilot and feasibility studies that are not using non-randomized, not using randomized design, which is observational studies. And we are also looking at how to do that. So this issue of consent, we're working on it as well. And outreach to other stakeholders about how to best approach this. We're working with some funding agencies in the UK about really how to best approach even the funding for pilot trials. For the time being, we've written some editorials specific to those people wanting to publish in our journal about really how to adapt the concept extension to pilot trials along with the spirit guidelines if you actually want to publish a protocol for a pilot trial in the journal. And we encourage people that there's certain things that have to do with designs and so on, and these things could actually be adapted appropriately for the protocol, because they would be essential to report in the end when you use concept extension to pilot trials. We did the same for non-randomized trials, trying to see or encourage people how to adapt the strobe appropriately and use the concept extension to pilot trials and just ignore all those items that have to do with randomization. And then we also, encourage people that depending on the type of study you're working on, you could adopt some of the existing reporting guidelines appropriately to be able to do a better job. Pilot studies really provide a good opportunity for us to assess whether main studies would be available. This remains and continues to be one of the primary reasons why studies are not successful. And the hope is that if you do a good job to assess feasibility, you enhance the probability of success of the main studies. And it's really the issue is about exploring those things that you're uncertain about regarding the main study as a way of enhancing success. Evidence seems to be very clear that they're not approached well with clear feasibility objectives. In some cases, it's not even clear why people are doing a pilot instead of going to the main trial. But if you're going to do so, we encourage that you should always link it directly to the main study and identify those areas of uncertainty which really justify why you have to do a pilot in the first place. We encourage people to have clear analytic plans, including criteria for determining success. This is about really helping you to be able to interpret what those feasibility findings really mean. Remember, in main trials, criteria for success is the minimum clinically important difference or effect. Same way you will need some guiding principle as to when you're going to know when you're being successful. Now, should we use them to calculate sample sizes or power calculation? The answer, yes, you could, but you need to be careful because estimates coming from pilot studies by definition would be very imprecise, and therefore one is to be cautious in using them. I often encourage people to actually use a sample size table rather than calculating a single number to acknowledge the imprecise nature of the information coming from them. We also encourage that they should be scrutinized the same way as full-scale RCTs. They require registration, and people should do everything they can to make sure that they're published, right? So careful design and conduct of these studies really has lots of benefits because it really can improve the clarity of the problem itself and see where the challenges are so that you can then have make better decisions about how you proceed and so on, including really this enhancing your chances of finding the solution if you can make the main study feasible by finding out all those things. So this becomes incredibly essential in informing the design of the main study, including its conduct, and certainly would, of course, ultimately improve the chances of publication, including really the efficiency of how you actually conduct that research and saving lots of costs. You can anticipate the issues and appropriately plan how to deal with them, including what resources you may need to actually put in place, or even find other collaborators that can help you to be able to enhance the chances of success for the main trial. Now, is transparent reporting of the results essential? Of course it is, because we do have a moral obligation to report all trials, whether pilot or not, transparently. And there's no reason to think that when it comes to pilot trials or pilot or feasibility trials, we should behave differently. We also have the scientific obligation to share the results about the lessons learned about feasibility to other members of the research community. And similarly, I've already shown you that we do have an economic imperative to do this because it saves wastage of resources in the process. Remember that a pilot or a feasibility trial is not a small single center study that you're undertaking because you don't have money for a larger study, which is typically what I often see people do, especially with trainees. So that's really not the best way to do it. They are done simply to be able to inform the design of a larger study rather than done because one doesn't have enough resources. They're also not a small study similar to somebody else's study that was published. I have seen this used as an argument to call something a pilot. And definitely, we don't often design them to show effectiveness of an intervention, but rather to actually assess whether it is feasible to do the main study. If you really want to check whether something does more good than harm or it has the potential to do so, that's a proof of concept study. And proving the concept works is not the same as proving that something is feasible. So quite often people tend to think that proof of concept is the same as proof of feasibility. Those two are not the same. this is Ghana. It's in West Africa. And for those of you who may have traveled to Ghana will know that it's one of those places where they use proverbs quite a bit. And they do have a proverb that says, you never test the depth of a river with both feet. The reason is very simple. If you do, you're going to drown. Pilot and feasibility trials allows us to be able to actually test whether we can actually do something and be successful in doing it in a particular way. And the goal is to allow us to avoid having to drown all the resources in doing the main study without guaranteeing that it would actually be feasible to complete. And with this, I say thank you, and I will stop.
That was an excellent presentation. I put a link, somebody asked about the checklist you have been presenting. I put a link to the consort extension checklists there. I think you did show a slide where you showed some of the other types of checklists like tidier, which I think for people who are developing interventions are really good to look at. And I also appreciate the ongoing work to help make some of the other tools like Spirit for writing protocols more relevant for these early and exploratory trials. I see that there's another question in the Q&A. Let me see what that is. Oh, okay. So this is something that maybe comes into the space just after perhaps a pilot and feasibility trial. When do you think futility designs are a good idea for say a middle phase study, or I guess possibly even in the feasibility space, the like setting, I guess, boundaries of if there is a chance there is this sort of effect, that it would be worthwhile to go forward. What are your thoughts on that?
Yeah, sure. Thanks, Will. I mean, before we do the main trial, there's so many possibilities of preliminary studies. I'm using the word preliminary, meaning that before the main study is done or the main trial is done. For those people who are really in industry-based trials, you have phase 1, phase 2 before you get to phase 3. We also have futility type designs that we also look at. There's also proof of concept studies. All these different versions, they're all trying to actually answer separate questions about perhaps whether there's a signal. And if there's a signal for benefit, is there also a signal of safety concerns and so on? So I see really, futility designs as about, closely more connected to proof of concept, where you really want to make sure that you rule out something that's not going to show any benefit as early as possible. But notice that all those things you may have actually done, you've shown that, something is definitely not futile. It definitely shows a lot of promise, and it's equally showing good safety profile. It doesn't necessarily mean that doing the main trial, phase 3 trial, would be feasible. So one always has to separate a concept where you're trying to see whether there's a biological activity taking place that would lead to benefit and less harm. You still have that to worry about, would it be feasible for us to recruit in a multi-center trial? Would it be feasible to get everybody to adhere to the protocol? Would it be feasible to capture all the outcomes and get good data sent to the coordinating center and so on? So feasibility is still a completely different aspect, which for many situations, we find that people tend to do a good job doing all these other preliminary studies, and then they don't do a good job doing feasibility, which is why trials or main trials tend to often fail. Is simply because if you're not able to actually recruit people, we could end up in a situation where something that's potentially useful, we're not able to see the signal or detect it simply because we don't have enough numbers. And the reason why we don't have enough numbers the challenges of feasibility of recruitment were never ironed out before we started.
There was another question that came up in the live box that was, do you have any explicit answer, or sort of an example of what you thought were well-designed go, no-go criteria for a pilot trial?
It's a very good question. I wish actually I could actually tell you exactly what the example is. We have a student who's currently working on that. So stay tuned. Maybe next time when I come, I'll have specific examples on it. So one of the students is actually working specifically to look at what would be the best way to come up with those criteria. And as part of what we hope to do is not only come with the guiding principles, but really also provide examples of best practice. So I'm sorry I don't have a ready-made example right now, but it's work in progress.
I can use one, I mean, I can give you an example. I'm not, it's an example. You could certainly talk about it, but I did a pilot / feasibility trial looking at a text messaging intervention for hypertension in emergency department patients. And in our early phase study, we wanted to really look at the proportion of people who actually went home and texted us back blood pressures and were still hypertensive. So we did it in terms of a single arm, but we had a threshold percentage. And we felt that, based on handing out blood pressure cuffs, which aren't expensive, but aren't free, that we wanted to be in the range of around 50%, that about half the people would actually be texting us back and would have both conditions, text us back and had persistent hypertension. And we had a planned sample size of about 150. So we drew a 95% confidence interval for 50% with a sample size of 150, which went down into the around 27%, I think, was the lower bound. And we sort of said that our criteria for success, our go no go criteria, was if we had a proportion that was larger than that 27%, that we would be in the zone of we're only giving away about half. We're only quote unquote wasting half of the blood pressure cuffs, knowing that it's certainly not a waste to give people in the community blood pressure cuffs, but from a research perspective, we didn't want to be losing so many people in that early part of the trial. We would probably have adjusted we had a plan, if the number was too low, then our plan was potentially to turn up the criteria and make people in the emergency department have a higher level of hypertension in the emergency department. So we had some sort of plan as to, if we didn't hit our bar, what would we do about it? That was one example we had where we used that. But again, it's sometimes there isn't an empirical answer. My idea that I don't want to give away too many blood pressure cuffs is not really necessarily derived from a biological truth. So I think sometimes, though, you do really have to think about, particularly in intervention trials or behavioral interventions, are you reaching enough people, and are they doing your thing enough that you can detect an effect from it? I think questions in drug trials could pertain to dosing regimen, adherence in the face of side effects, and some of those other things. But I think many of the important studies in the pilot and feasibility space are really in terms of the regimen. This protocol that they're filling. Can people do it? Will they do it? Do you need to make tweaks to it so it's easier for people to do? And sometimes it's like a matter of, if you're thinking about doing a large number of surveys or instruments, just how long is that going to take? So you almost need to do some pre-work even before an actual pilot trial, just to understand the data collection burden.
Sure. The other thing I could suggest, Will, is remember the talk I last gave on this topic, which we videotaped. If that videotape is still available, in that session, I actually go through the basics, including specific examples of really how to think about this. And I had maybe 3 or 4 examples of studies that were well designed with specific progression criteria and how those became helpful in determining whether to move on or not to move on.
Yeah, no, I think that those should still be available on our website. So we'll I think we can dig up that link and send that to the participants here. All right, so we have another couple questions, and thank you for all the participation from the audience. So the next question is, it seems hard because you want a clear criteria for whether you met your pre-specified target, but because N is small, your measurement's inherently more noisy, as you said. Yeah, and that is one of the things that if you, you could take my example of feasibility and extend it a little bit differently, right? Because I'm doing a summary measure of patients, but the patients are texting us back multiple times over the course of 12 weeks. So there's other ways of looking at it: time to getting ghosted, time, how many people are actually getting through to the end, that can help give you sort of different insights into the feasibility of your intervention package. So when you do have multiple, you can sometimes learn more from each patient in these early phase trials about more granular aspects of your intervention or protocol, and those are opportunities that are well, it's time well spent to learn about the patient experience and why those things may be, why people may be more or less compliant with parts of them, or they tend to drop out or fade away from the study. Another question from Dr. Charleston. Are there specific criteria for the percentage feasibility measures or proportion of patients who participate? If not, do we derive these from published RCTs? And I will see what Dr. Thabane thinks about that.
Yeah. One of the reasons why we are still working on this is because it's, the guiding principles are not published anywhere. So people really don't have some guidance of how to approach these issues. But I often say, what you really want is to come up with the criteria that could actually be useful. It's context dependent. Let's say, for instance, you say, well, if I'm able to actually get people to comply 50% of the time, I would consider feasibility of compliance, acceptable, and so on. Yeah, sure. The lower the bar, the higher the chances that you'll succeed. But in reality, it may turn out that for you to actually demonstrate that the intervention or the therapy does more good than harm, you will need more than 50% compliance to be able to demonstrate that. So I think you just have to be realistic and try to aim to use criteria that will really provide you with useful information about feasibility of the main study, given the goal that you really want to design the main trial for. So I would say common sense dictates that we should always be practical, of course, but also be realistic.
Yeah, and I also think that for certain things where there's more complexity, more complex interventions, sometimes part of the design is finding people for whom that is a good fit, right? Like, exercise works great for a lot of things, but getting people to continue to exercise requires resources, coaching, and even with all of those things, somebody might start to develop knee arthritis and not really be able to stick to the exercise. So I think you have to think about throwing out, sort of the baby for the bathwater, in that if there is a subset of people who really adhere to the intervention, and there are ways to, through your design, dial in on those folks. Not every intervention is for every person. So ways that you can kind of enrich your population potentially can help you. Otherwise, it can be very hard to interpret studies that have a ton of loss to follow up. Or studies where you're really, you have enough compensation and enough, because you're following people in clinic and they have rare diseases and they're kind of easy to keep track of, but they sort of fade away from the intervention part. So you can get a lot of outcomes, but they didn't do a lot of stuff in between. And I think part of it is, if there are things that maybe that involve a lot of effort, right? People are like, I'm going to design a gamified app and people are going to interact with it 5 times a week. Most people don't end up interacting with those things 5 times a week, other than, Facebook and the New York Times app, like some of those things that continue to suck you in, that are designed by the people who design advertising. But in terms of the stickiness of some of our health interventions, the fact, if 20% of the people you expose to it end up using it a lot, finding a way to drill down on that population is good. It's also, but it's a different crank, right? If you can expand the population who will become really engaged, that's also important. That's one of those early phase feasibility questions. But I think one thing that we have to keep in mind is that there's going to potentially be a group of people who we're going to lose. And depending on the risk, right? If it's a drug and we lose people because the drug is toxic, that's very informative and important in terms of thinking about how that drug treats a population. If it's an app-based intervention, there's often less sort of risk of toxicity, but it's also just important to know that it's not going to be a good match for everybody. So how do you drill down on the folks that are most likely to stay engaged? Because it is within them that you're going to have the best chance of showing movement on your outcomes. If you have a lot of people who aren't doing your intervention, they will just add noise to your study and make your final study harder to do. Well, are there any other questions? I think oftentimes we're all on back-to-back teleconferences, and I do sometimes really try to get us out a few minutes early so that people can get up and stretch, or at least my Apple Watch tells me it's time to stand up. So if there aren't any other questions, I think we will put in the link into the chat for the evaluations. Hopefully we will send the link. Like, hopefully Emily will track
it right now.
Okay, Emily will track down that link. Perfect. And I think with that, oh yeah, that link's up there. Perfect. So yeah, please send us an evaluation. Thank you for spending some time with us, and Dr. Thabane. It is always a pleasure to hear you talk, and thank you for everything you presented, the proverbs, and the also the just recognition of the where your institution is, and who you have to thank for the land. That was I was moved by that, and I thought that was a really good way to think of how we are reflecting the indigenous people who've been here a long time before us.
Thanks, Well, thank you again. Now, I know we have another session scheduled sometime in the fall. If you can let me know whether the plan will be the same as this or we'll revert to our previous plan, please let me know, okay?
Yeah, no, I think we will be in touch. I think we had some different ideas about a sort of a different area of topic, but I will definitely be in touch with you since then.
All right,
so
okay, all right, that's fantastic. Okay, all the best to everyone.
Yep, It's good talking to you all today.
Bye-bye.